I'm sure she has a lot to tell us. Dr. Kini.
Yes. Are we showing live case number 3 by the side?
No, we're showing, we're going to start number 3, but we want to hear about number 2 first. Number 1 case, how did you end up in the other room? Case 1.
The flow of the vessel came back. We just left the vessel the way it is. Yeah.
Okay, good. And you IVISed and all looked good in the left main. So just a single stent to the LAD. Excellent. Okay. Live case number 3.
This project.
11 minutes. Let's go.
So if you can see the live case number 3.
Yeah.
It's a 67-year-old male who had initially presented with positive stress, stable angina, had a CAT, 3-vessel disease. His other vessels, which were RCA as well as a circumflex intervened. He has a lot of risk factors here again, hyperlipidemia, diabetes. And now here he is for, LAD diagonal bifurcation. Just want to show you the entire angio. This is a PDA.
Oh, wow.
EF is good. PDA stent is okay. Circ stent is okay.
Okay.
So mid-LAD, actually bifurcation D1 and D2.
Very interesting. So it's a double bifurcation. I'm sure there's an app for that. But before we go to your app, tell us what you're doing. It looks like you're doing OCT or imaging or whatever you're doing. What are you doing? Yeah,
we tried to do OCT. The calcium, I think, was not allowing. That's why we synate that amount of calcium there. And I think a tight lesion, the catheter would not go forward.
Okay.
So we change, this is a calcific LAD. So instead of atherectomy, we're going to atherectomy. This will be orbital atherectomy here.
Okay.
Now you can ask the panel how would they otherwise tackle.
So here, though,
we changed to Viper wire.
Okay. So it looks like you're doing
and we are
orbital
ready to
here.
do the atherectomy.
Let's start with John LaSala.
Yeah, I started to make that discrimination early on about what I do with rotablator, what I do with orbital. This is a better one for orbital. It's not like this heavily calcified super 98% lesion that has a great deal of length to it.
And there's no angulation. It's kind of a straight shot, right? Because I worry about the angulations with orbital. Does anyone else have those concerns or no?
I worry about angulation with any one of them.
Any of them, yeah, of course.
Orbital actually does a little bit better with some of it. Yeah, rotablator's not. Rotablator, of course, will gutter if it has a severe bias, right? So it won't go through the lumen that you see. It creates its own lumen when it has a severe angulation because it is spinning at a much higher speed and has a lot more power. Orbital kind of will adjust a little bit more and accommodate those bends, so it actually does a little bit better, I think, in those situations. Yeah. This is a perfect one for orbital.
Dr. Patel,
your comments? I was going to agree with that. I think I would think about orbital in this scenario because of that. And then I just as you said about angulation, I think the other thing to think about is the speed of what you're doing. It's not the rotablator speed when you do orbital, so it does deliver and do it, but you have to just go a lot slower than.
And it's kind of doing it. As you go forward and as you come back.
So the advantages are you can use it going forward, going back, and you can go slower, and you have flow around it. But I would say I haven't seen an appreciable difference in no reflow.
No. Yeah, I think you see in our lab, we're very proactive about atherectomy, use of atherectomy. I'd love to hear from Holger. I know that in Germany, you guys are not so into atherectomy, or maybe you are. I don't know. Tell us.
Yeah, no, we are also active with atherectomy, but we are mainly using rotablation because we currently still do not have the orbital atherectomy in Germany. So it's one of the few things where the Americans are faster than the Europeans. I'm kidding. Probably for this patient, we would also go for rotablation.
Bill, you said you're a minimalist. What would you do here? Would you do orbital atherectomy, or would you just go with atherotomy or lithotripsy? Or
I think imaging would be nice to understand exactly how much circumferential calcium you're dealing with, but we would probably lean towards just rotational atherectomy with a 1.5 burr.
Yeah, slow.
All right. So
we're starting with the orbital at 80. We have very good reflow on the left main, so we wash out all the embolization.
Can come out.
And we did it at 80 speed. So
Okay, start coming out.
we did
Yeah,
two
glide
runs,
assist.
30 seconds in between, and we're removing the orbital. Now let's take a peek.
Now, if we were able to image, okay, depending on the amount of, we can show the calcificate by the side, based on the imaging, how you decide which atherectomy you want to use. Actually, what we showed, if you have severe calcium, which is more than 3 quadrants,
This is the run through wire.
OA works better.
Okay.
What we showed that if you have moderate or mild calcium and there is presence of fibrous tissue, lipid in the other quadrants, that is the time when you see that it causes a gutter, because this actually causes cut and causes gutter. So it's very important, yes, like mentioned, that imaging, if you need to decide which atherectomy device you want to do, imaging is important, like we tried here. But since the imaging catheter would not go because of the amount of calcium and severe stenosis in the LAD, we made a decision based on the angiogram.
So will you image now or will you proceed? What's your plan?
Not now. I think look at the flow. Yeah.
Gutter.
Okay. So now
And
you
see
just
that,
want to proceed.
this is one, that's a wire of the orbital atherectomy wire. There are 2 of them, wire advance,
Filter wire.
flex wire advance, and the floppy. So basically you see the little gutter has been created in the angulated lesion. So this is one thing we want to avoid. And of course, you need to worry about the perforation and so. But here so far, as long as within the gutter, many times, in those cases, you may have to exchange your wire. Usually we go side by side. But if you have created a gutter, it's better to go with the over the wire system you already have, which you used to begin with, and so that you remain in that lumen.
Yeah. Because I see a little bit of.
But anyway, so always we go side by side, like other side also. We went in that LED side by side.
Be good.
You see a little dye?
Some dye, or we have to go with the fielder fine cross, right?
I think this is the case with the nothing.
Yeah, get me the fine cross.
Leave it in the diag. Leave it in the diag.
It's actually going to the D2. This, I think we may dissect.
Let's exchange with the fine cross.
Okay. Get the fine cross?
Yeah.
Yeah, this is another teaching point. So for a lot of our audience,
safer.
so they always say that, do you need to change over the system? I would say that if you see any gutter, you see any dissection, then it is better to see, like in this particular case, you see that you have created that dissection
there's definitely a dissection
which is
proximally with this,
Yeah.
you know.
Yeah, exactly. So I would say in atherectomy, the dissection is your friend. As long as you don't lose the lumen, don't lose the wire in the lumen.
300 run through.
So this is what we are going to do now. Fine cross, change to the 300 and dilate with a balloon. And then I know that we are on the time today. So in next 2-3 minutes, we are going to end this case and you go to your very important the revascularization guideline session.
Yeah,
and we'll update you just to say on my side. LAD was so good, so we did not do anything to the diagonal. Anu, you want to say now?
I'm actually quite interested in this case, just to see how you proceed, especially for those 2 diagonals, whether you'd be wiring them beforehand and all of those things that we talked about in the first case. But your Bifurcate app will tell us otherwise, but I'd like to just know how you are proceeding. So now it looks like you're going over the wire. So
our first goal is to stabilize the LAD. We will get the wire into the LAD. Like we mentioned, I tried side by side, could not do it. Then we use the same fine cross. And now I'm using a long 300 wire to wire the LAD.
Yeah.
Too much back.
And then
what we'll do is wire that diagonal. Now, ideally, we want D1, which is a larger vessel. And I think in this particular case, we will leave the D2 alone.
That's good.
So at the risk again, Antonio brought up of driving up the expenses. This is actually a good spot for a dual lumen catheter. So you don't have to traverse that dissected plane a second time.
I know that we're going to.
We already had the fine cross to use in the beginning, so you just use the same catheter.
Dr. Puskas.
I know we're going to have a discussion of indications and revascularization guidelines. the presentation of this case was quick, and I may have missed it, but am I correct in understanding this is an otherwise healthy 67-year-old gentleman with 3-vessel disease and diabetes?
Yeah, I think
Yes.
that's correct.
Was there a heart team conversation about the Freedom Trial and his outcomes, and what will we expect his survival to be
No, but
relative to a
John,
coronary
in
bypass
this case,
option?
there was only LED diagonal bifurcation. Other vessels are less than 50%, 30 to 50. It was single vessel LED diagonal bifurcation with a syntax score of 9.
No, that was PD and
I'm sorry, what?
There
PD
were
and OM.
previous
Oh,
stents
PDF,
in
that
the
had been done
circ.
before. That time you had a discussion, right?
Yeah.
Yeah.
He did have a discussion before
Yeah.
at 3-vessel disease when he was 3-vessel disease diabetic, and it was decided the same. They were spot lesion. I think that's what we need to revisit. Very important that yes, diabetic 3-vessel, but this guy had spot lesions, and during the discussion, patient wanted a PCI. So that's why in the first sitting, the OM and the RCA was taken care.
Yeah. But very important point that heart team discussion has to be outside the room with the surgeon, cardiologist there. Then only it is validified, because on the table, the threshold going for intervention is very high. So it has to be outside, and that was done in this particular case. And you're right. So now it's the residual syntax score was 9 only. That's what left here. And so having the main part done after the discussion, 2 spot lesions, right? Both of them were taken care with the 2 stents, short OM2 and RPDA.
Yes.
And here for LED diagonal bifurcation. But yes, there are 2 diagonals. The second diagonal is small. I think just take care of the main one, and then you decide whether likely mini crush, right?
275.
Yeah,
So
it will
that
be
they
mini
can
crush.
go on the lecture. So tell us what your strategy is.
Yeah, because
Roxana
we
can
want to
take,
go
for the
straight
next
to the
session. Yeah.
lecture,
So
and
we're
I'd
going
like
to predilate the
keep our
LED.
panelists.
Going back to the same point, in this particular case, I think about bifurcation. For people out there, we have to know bifurcation all depends on the side of the, size of the side branch. The size of the side branch, the disease of the ostium, and the length of the disease in the ostium. So if you go into this case, the LED diagonal is same size, is a 80% lesion of the side branch, and the length of the side branch is greater than 10 millimeters. So taking everything into account, to begin with, this has to be a double stent strategy. So we will predilate the LED, then we'll predilate the side branch, and we will use a mini crush technique.
Okay, so please, Floro, save everything, because when you come back at 11:15, I'm expecting to see the final results of all 3 cases very quickly for our audience. They're all eager to see. There are some questions also. Please feel free to send your questions to me. Most of them have been addressed. Some have to do with side branches, etc., that we'll discuss again. Thank you. Thank you, Dr. Kini, Dr. Sharma. We're going to go now.
Okay, good. I have the entire cath lab team behind me here who have helped me with that case. I have Dr. Moreno who was with me in that case. So if you can show the angiogram, are you able to see the angiogram?
Yep.
This is where you left us, that we wired the main LED. Then we wired the diagonal, and this was just a balloon. If you see here, after the orbital atherectomy, 2.75, 20 balloon, good expansion. We did a cutting balloon of the side branch. This is what it was, and I think I did mention, since the diagonal was a large size as the size of the LED, we did plan 2-stent strategy, and we did mini crush technique. If you see here, it was a 2.528 in the diagonal and a 2.7533 in the LED. All the steps. So this was the final result. Now, we need to recross and kiss. But especially when there is calcium, we do face this problem. That even though I was able to wire, no balloon would go into the side branch. So what you do in that, if you see here what we have saved, if you can actually see it, is a 1.25 balloon. And what we call this is a balloon anchor technique. You go 1-to-1 balloon size to the LED or the main vessel distal to the side branch, go high, about 10, 12 atmosphere, and then you get into the side branch. You see, this is the fluorosave. Are you able to see how I was able to get the 1.2 balloon into the side branch on the fluorosave? You can see.
We see it. We saw it. Yeah, we see it right there.
This is called a balloon anchor technique, which is very helpful when you have calcified, bifurcation lesion like this. We went, then we did a kissing balloon. This was the final OCT, and he will take over now. Pedro?
Okay, so we're going to play the OCT. We're going to start from the distal reference. You see that, you see the position of the stent is pretty good. This is after the diagonal. We see no malapposition, and there is very little disease there behind the stents. We see some narrowing now. There is a side branch, and very early we're going to come to the bifurcation zone. So the bifurcation zone is going to show right now. So stop it there. Go further in. Okay, so this is what we are looking for. We're looking for the double lumen, like a neocarina. So if the mini crush is properly done, you will have struts creating a new carina. So this is not malapposition, this is just a double lumen. You see the stent in the main branch, and you see the actual area in the side branch. Just keep coming back. And then we're interested in looking at the proximal segment. You have some plaque protrusion. There is a little dissection at 3. Coming back, we still see the double lumen. And now this is the prox LAD, that is a much larger vessel. We're still in good, and this is the reference that we have a little dissection. So in order to analyze this OCT, you can actually create a whole segment, or you can divide it into 2, because the proximal reference area is 6.2 square millimeters, and the distal reference area is 2.8. So if you apply the formulas of the 95% of your MLA, you're going to be distracted. So you divide into 2, the proximal segment and the distal segment. So if we divide the proximal segment with a proximal reference area of 6.21, we have a proximal MSA of 5.87, which is 95%. Over 95% is optimal. And if you go into the distal segment after the diag, we have a proximal distal reference area of 2.86, with a distal MSA of 3.41, which is 119%, which is pretty good. Now let's present the slide that I have.
Please show the slide.
Yeah, just one slide, very briefly, because I think Dr. Prati did this classification that I think is very important for us when we use OCT to evaluate suboptimal stent deployment. And there are 5 parameters. One is the edge dissection has to be more than 200 microns. We actually measured both dissections here, and there was 112 microns, so it's below. You can show it there. It's below the 200 microns, so you don't have to do nothing here. We also measured the actual stent protrusion, plaque protrusion, that it has to be below 500 microns, and here it was 200 microns over there. So very nicely measured. The plaque protrusion is 200 microns, so it's below 500. You don't have to post-dilate, nothing here. And the areas that are 4.5 distally, we have actually 5 point plus in the proximal, which is okay. And there is no malapposition or incomplete expansion. So this is an optimal stent deployment. I have to say that if you don't do this, 31% of your cases will be suboptimal stent deployment. Just to let you know, I mean, that there are trials going on for this, like the Illumin 4, in which this protocol is applied.
Wonderful. Well,
thank
this
you,
is a
Roxana.
great result.
Any questions
Thank you.
we have?
Thank you so much. I think the only, there's
okay.
one, I don't think there's a question. Maybe Dr. Kwan, did you have a question?
Yes. This is a nice case. Dr. Kini, Dr. Moreno, congratulations. The reason the 1.25 balloon cannot cross the side branch, do you try to rewire the Y first, or you just go into the anchor balloon technique?
We rewired. We rewired twice. Very important point, by Dr. Khan is the same thing. Is that if you are unable to cross balloon, first thing you do is rewire. Then people do say do a pot, but pot is very important if you cannot wire. That means your proximal part of the stent is not well opposed. So pot is important if you cannot rewire. If you already rewired and the balloon does not go, you go to a different cell strut and then go with the same balloon. If it does not, anchor technique with a lower size balloon. All these steps described in Bifurcate 3D and Bifurcate, original Bifurcate app. Thank you. Now go to room 6.
Wonderful. We need to go to room 6 now. Thank you, Dr. Kini and team. Beautiful representation of a great